Sometimes asking, "Are you okay? Are you okay?" It just makes it even worse for someone who's not ready to open up, whereas just being there quietly is enough. And that's all I did was just in the room charting instead of at the desk charting. I'm Dr. Melanie Fant. I'm located in Memphis, Tennessee. There are times working in labor and delivery where you do not, sometimes you really have to be really open minded and not judge because you don't know the full story. I had a patient that I was assigned to. It was a fetal demise, and she was laboring. And I remember her G's and P's, her gestational being like really high, something like a G7, P4, or something like that. She had multiple births, but no living children. And what I received in report was that she was closed off, very kind of attitude. The nurse just seemed like she had a bad taste in her mouth about the patient and that she was trying to make a connection, but the patient wasn't really as receptive. Her husband was at the bedside. I remember walking in the room, it was very quiet. Obviously, this is a demise patient that's laboring, so you have to be very sensitive and understanding. And, not as I guess your typical chipper approach that you would have with birthing or helping assisting with births. I just kind of used a way to try to connect with her without doing too much. I feel like doing too much was kind of making her be more closed off. And when I say doing too much, I mean trying to make conversation and pulling information out of her. I could just kind of let her open up on her own. Her husband was very quiet. He didn't really seem engaged. He didn't really talk to her. She mainly talked to me when I did my assessment. She eventually labored and delivered. When she got ready to push, that's kind of what made her, I would say, it just everything cracked. Like she just let all of her emotions out and she just kind of explained to me, I've had multiple miscarriages. She had multiple miscarriages, neonatal deaths. I think she had two that actually made it, but they died. And then she had multiple stillbirths. And she did know why. She said, I'm not sure what I did to deserve this, why this keeps happening to me. I didn't try to get pregnant. It happened. And she was very apologetic, like I'm sorry. And I felt just so empathetic in that moment because the whole time I think the staff just felt like she was just not a friendly person. I think the staff felt like she was closed off for whatever reason, and they just lost. I think, when you try to connect and it's not working, they just kind of gave up. And she had what would look like an emotional break. I mean, just sobbing, crying, like, I don't know why this happened. She said she had done genetic testing, her and her husband. They don't know why they kept losing their babies. And so I actually stayed over for that delivery and recovery of that patient before I took her to the other floor because I'd never heard such a heartbreaking story in my life. Of all the demises that I had, that was the most heartbreaking. And I think in that moment, I noticed she didn't have her husband for support because he was probably going through his own thing. And that she just needed a person to just let it out to who didn't judge or just was listening. And I remember at the end of taking her upstairs to the other room after she recovered, after she got to spend time with her baby and things like she gave me like the biggest hug. And it just kind of changed my perspective that it's so many different types of walks of life that come into labor and delivery, different types of backgrounds. You have no idea. Sometimes that stigma lies where you see so many losses and you assume it's, you know, some people assume like it's maybe abortions or they assume that someone was careless, and those women and moms are carrying that as well, that shame of I can't carry a baby, I just want a live baby with my husband. And I felt that. I don't have children, but in that moment I felt what I think she was feeling in that moment, and I just couldn't help but to just say I'm just going to be here with her and be her rock. I will say, my me personally, when I'm going through something that's difficult, or I'm sad, or I'm grieving, I don't outwardly emote. I typically bury it, or I kind of come across like I can handle it, and I tend to isolate a little bit. And sometimes, and I have been in on the receiving end of someone feeling like I've just had an attitude, or and I didn't have an attitude. I just maybe was a little quiet and not as, outgoing or chipper. I might have been very solemn and calm. But sometimes people pick that up and perceive it as you're not friendly, and it's a negative connotation when really you're going through one of the hardest times of your life. And so I noticed it because I tend to have this stoic look as well when I know something is really heavy. And what I know is my solution is you have to let me come to that point where I can share it. I'm not gonna just outwardly pour out and vomit all my emotions out to anyone that I don't trust. And so, labor delivery, you have multiple shifts of nurses that are coming in. She doesn't know us. She doesn't, she's had multiple losses. She's come up in here multiple times to have losses. She is probably emotionally tired. I kept thinking she's tired of this. She's tired of feeling this. Who knows what discussions and dynamics are happening between her and her husband who can't have a baby, and what she's feeling. She probably just, got cold and shut down, and I figured that much. So I just didn't keep trying to get her to open up, and trying. Sometimes asking, "Are you okay? Are you okay?" It just makes it even worse for someone who's not ready to open up, whereas just being there quietly is enough. And that's all I did, was just in the room charting instead of at the desk charting, and, you know, a calm demeanor, and she just kind of just let it out. I guess she felt like she could trust me to let it out. Most labor and delivery nurses and postpartum nurses, we are used to seeing the positive outcome. So it is a very happy place, a very uplifting and encouraging. We're labor coaches, we have this upbeat spirit, and it can be heavy. Somebody just lost, or somebody is laboring and going to walk out without a baby that's alive. So that is very hard. I would say after every one of those heavy shifts, I did take that home with me, because it's just so heavy and it's just so devastating. And the only thing I can remember that I did do was journal it out, to just journal how I really feel. As someone who wants children, that is a fear. I think that's a fear of any mom. Nobody wants to have to go through that, but it's one of those things you just don't know. It can happen to anyone. And so you do have to kind of journal, or if you take it even harder than that, maybe seek therapy. I would equate that to someone who maybe works in like a trauma unit, or um, any EMS first responder who sees a lot of like tragic things. You can take that on, and you do have to find a way, an outlet to get that out in a healthy manner. So I would say for me, I journaled. I just have to remind myself that we are taking care of women across the lifespan. You have young teen moms and you have older moms. You have moms that are new moms. You have moms that have had multiple children, moms of different cultures, some that aren't even from America. And you just never know. Its perspective is everything, and experience really molds the current. And so I always kind of center myself in knowing like this might be my coworker seeing things through her lens that may not be factual, or we don't know what transpired at home with this pregnant patient, and she may not have the best attitude, or she may be in pain. She is in labor. And all of those things translate differently. One lady can be in a tremendous amount of pain and she's just sobbing, crying, and another patient could be very angry, and another patient could be completely stoic, and you have no idea. We've seen it. A woman could be 9 centimeters and have not make a peep, and she's going natural, but then you can have a woman that's climbing out the bed in pain. So I always center myself in knowing like we're each going to have a different perspective when we walk in the room. You have to be open to knowing that it may not be personal. Like, it's not a personal thing. They're going through one of the most pivotal times in their life, childbirth. So you can't take it personal, because it's really not about you and your emotions. Just go in the room and just try. We don't have a choice. We're the nurses. So you're going to have different walks of life in there. I feel like in an area like in the maternal area is you really do have to individualize care and not standardize a lot of things as far as because it's family centered. For example, you may have a mom who went into labor out of nowhere. Is babies come when they want. She may be new to the area. She has multiple children, no help, no one to take the kids. She's coming into labor and delivery because she's in labor. Who's going to watch the kids? There have been multiple times that we've had to, and our unit isn't equipped with the daycare or child care or anything like that. You just have to maneuver and figure it out. There's been times we've had patients labor. We had to watch the kids at the desk or somewhere that's not in that area, and we had peanut butter and crackers and juice to give them at the desk, or things like that. And somehow it worked out. That's her individualized care. For those with loss, we would you try to put yourself in mom's shoes as much as you can. And I think that's the best way to approach it. If you have someone with a loss, you may think, if I know I have a stillborn baby and I have to deliver this baby, I don't want to be around people who have live babies that are crying and they get to have what I thought I was going to have. So we would put them in a room that's a little bit at the end of the unit that's not neighboring another room that's actually laboring a live baby. Things like that. I would say you just sort of position yourself in, what if I was in her shoes? There are lots of unique experiences that happen that you never thought would happen in labor and delivery. I mean, we've had patients who husband was deployed in Afghanistan, or husband tragically passed away, or they were going through a divorce. I mean, life things happen. A lot of life happens in the midst of the good stuff, like having a baby, that you do not prepare for as a nurse. You don't think it's more than just passing the medication or helping her push. I was a baby nurse, so I was so focused on checking the cervix and getting her to push and have a safe delivery. It was very simplified in what I thought my day-to-day was. I'm more than just a doula. I'm more than just a helping with breastfeeding and things like that. It is so just comprehensive. I'm looking at the educational gaps or needs with my moms and what that could mean for babies. It's a full circle of nursing. I really wanted to teach in reproductive health because I feel like there needed to be some more development in a true maternal health nurse, like in postpartum, labor, and all of that. And so how I help to really evolve that and mold those type of nurses is that when we're teaching, I teach in clinicals. I take groups of students to clinical pretty much weekly, labor and delivery, postpartum, and NICU. We're not just looking at assessment and nursing interventions. We're looking at the social and family dynamics. We're looking at the patient education needs. Some patients just don't know what to tell you. Some patients do not speak English as a first language. What are you going to do? And so it's really unique. It's really fun to kind of show them how each of those areas impact the other. Your patient's obstetric history will impact your assessment. Your patient's social and family dynamics will impact their educational needs, because it's more than just hanging Pitocin and coaching them on pushing. You're also telling them the importance of vitamin K for their babies when they say, I don't want to give any shots to my babies because they're afraid. Or the mom who maybe just doesn't want her baby out of the room because she's afraid you're going to snatch her baby up and she won't have a baby anymore. That she's seen maybe some movies about people snatching babies, and there's an opportunity there. Some of these myths you can dispel just by simply educating and talking to your patient. And I teach my students that most of them are Gen Z or a little bit younger. And I noticed that a lot of times they want to just look in the chart to piece together their patient and what to do. But they don't think about how much talking to the patient is a lot to do with this type of nursing. You can learn so much and you can get so much done just by making that connection just from talking and asking them questions about the other kids and things like that. It works wonders. So watching them make that start to piece together that type of nursing, and it's like a light bulb goes off. It just makes my day. I love it. I love this side of nursing where I can kind of mold new nurses into really looking at nursing in a comprehensive view? I would say this specialty is not the easiest. A lot of nurses have this belief that it's like baby land. It's happy land. It's soft nursing is what I hear my students say. Soft nursing, and it's not hard. A lot of them give bad rap to areas like med surge, and they assume that labor and delivery is the easier side. It's not that easy, and I'm very passionate about the care that I give, so much so that I've done research on this area. I really do am passionate about the education that I give because I want more nurses to have more of a comprehensive approach to their patients. You can miss a lot of things just by not assessing just mindset, or more than just looking at the clinical picture of a patient. And I like that I'm not alone in that. It's a lot of other seasoned labor nurses who agree. It's a comprehensive approach, and it is a lot of family centered approach when it comes to that. So this series is probably going to be very eye opening about the true essence of maternal health nursing.